Good afternoon. I hope everyone can hear me. I thank you guys for taking the time out of your busy days to come and listen to the presentation this afternoon. I know we have some different goals than we normally set during CE presentations, and here, while we want to frame the conversation, obviously within the context of clinical education, we really want to focus in on specifically on the product pieces that we're looking to utilize within the group, making sure that we see the benefits and the features of the products that we really want to emphasize and make sure that as an organization, you guys are able to take advantage of. So we'll take a look at really overcoming the challenges of direct composite restorations and how we can optimize the clinical results, specifically using our products, hopefully to get to that idealized result. So when we start out here, we'll take a look at a simple class 1 restoration, or at least if we had a choice in the morning when we walked into an operatory, whether or not we would hit an easy or a hard button on this. Most of us would probably hit the easy button for a class 1. Even recognizing that preparation, caries removal, isolation, adhesion, material placement, occlusion, and finishing and polishing all factor in to the clinical outcome, we still generally recognize these as being a reasonably simple procedure to do, or at least that's how we would categorize this. Yet when we look at each step, we have to realize that the preparation itself, so whether we are looking at the ability to have refined margins or areas within a margin that are beveled or appropriately prepared, and that can affect the adhesion step. So preparation is tied to adhesion. From the adhesion step, the material that we're using, right? Are we scrubbing self-etch materials in place? Are we allowing total etch materials properly placed within application technique? Are we utilizing those materials correctly? And every step along the way matters. Light curing, certainly another component of things that we do that we usually are a spot in our presentation or in our procedure rather, where we kind of take a deep breath or expect that our ability to contaminate field or to impact the longevity of the restoration is kind of over. But the reality is this is an important and a critical factor and step in what we're doing. Application of the composite material into the preparation. So with the irregularities of the preparation anatomy and making sure that we have good adaptation, what techniques can we utilize, what materials are the most appropriate for each of these clinical indications, and certainly material placement into the cavity prep is something we've focused on in the past, but as we look at the complete spectrum of start to finish is obviously a critical step in completing the procedure successfully. Looking at finishing and polishing, so the speed at which we polish, the amount of heat that we generate as we're finishing the materials. As we polish, are we able to bring materials up to a good luster and have a good surface quality? And this will impact the longevity of the restoration, its ability to fend off stain, to exhibit or lack of exhibiting marginal discoloration. But each and every one of these steps factors in. And we can complete the final restoration. So here, can kind of see some white lines around that preparation or around those margins, and that can be impacted from the type of preparation, whether or not we beveled those edges, our application technique for the adhesive, the speed at which we finish and polish may have impacted the integrity of that bonded interface. So here, while we may have categorized this as a simple class 1, the reality is the result is far from perfect due to the visibility of these marginal white lines, and the reality is several steps along the way may have contributed to what we're seeing. On the flip side, we generally categorize class 2s as being complex, yet a lot of those same issues still exist and are magnified because of not only the class 2 preparation, but where the materials are being cured, location from our light source, how far down in the proximal box they are in relation to the gingiva, our ability to isolate those fields, right? So again, we look at each and every step along the way, and certainly we can impact or have impact on our final restoration. And really what we want to look at today is our end-to-end solution of being a class 2 solution. So today we're really going to focus in as you follow this spectrum from bottom to top or from left to right, really focusing in on several of the products, one being Paladin Plus, another being Prime and Bond Elect. We'll talk about SureFill SDR Flow, TPH Spectra, our universal composite, and touch just a bit on finishing and polishing. I do have several sections that would be expanded. Normally, we would do this course in a 4 or 8 hour segment, and realizing today we've just pulled some of the features and highlights out of that course to fit our schedule. But what we're really trying to achieve with restorative dentistry is from an immediate standpoint, we want symptom-free patients. We want our good immediate results to translate into long-term success, which is really based on durability and longevity of those restorations. And we'll talk about that, what impacts that in just a minute. In kind of modern day technique, we're really looking to maximize natural tooth structure. And quite often in the past, we had been implementing extension for prevention type concepts. But in reality now, our armamentarium, our delivery system, our ability to isolate, to create separation between teeth, so many of the contributing factors that led into extension for prevention concepts really aren't at the forefront of how we should be teaching and looking at doing clinical dentistry now. And certainly maximizing natural tooth structure is of paramount importance. We're at a point in material development where we could really look at achieving the best dentin substitute and the best enamel substitute for the tooth structure that we're replacing. And essentially, we want to rebuild the tooth from the inside out. So let's start focusing in on some of this stuff. The composite and resin materials, we all should know, are composed of a resin matrix and fillers. These filler materials can be of various substances from glass, quartz, silica, pre-polymerized resins, and all those are incorporated to reduce shrinkage. So as a general formula, we were taught in dental school that the percent of resin plus the percent of filler equals 100%. Resin is the component that shrinks. Shrinking is bad. So ideally, we want to seek higher filled percentage materials. And there's some truth to that, but the reality is just because a material is by percentage or by weight filled more than another doesn't make it a superior material. And these are just some of the myths that we'll work to dispel as we work with the groups and work towards integrating our product solutions into your clinical environments. And these fillers can influence the material based on their size, their shape, their surface quality, their optical index. And a great example of that nowadays is nanotechnology. Nanoparticles actually have a very different way that they reflect and refract light than larger size particles, and can actually wind up with significant variations in color, and especially regarding translucency when we compare nanocomposites to other composites. But the materials themselves, as we mentioned, are resins and fillers, but also have coupling agents and pigments, UV absorbers, which allow us to work under natural light sources or under our operatory light sources, inhibitors to give us the ability to have prolonged work time, photoinitiators such as camphorquinone, which are what triggers our light-based reaction. And certainly the polymerization mechanism is controlled by the companies, by our base chemistry to dictate how much or how quickly these reactions polymerize, how completely they polymerize, and certainly impacting the shrinkage, volumetric shrinkage, and the overall performance of the materials. If you take a look just categorically at what we have on the screen, many of you will probably recognize some of the categories of materials and may even be familiar with some of the particle size associated with those. I would tell you quite honestly, as both a clinician and a researcher, I put very little value categorically into where the materials perform, because a lot of this has been created by rating agencies and manufacturers looking to differentiate products, and even providing indications for microfills, for hybrids, what might be the most of an advantage. But the reality is, for us as clinicians, we want materials that are simple to use, that are robust in their application, so they're a little bit forgiving for us as clinicians. We want them to handle well, we want them to polish well, and I think the best we can do for our composite is kind of forget about it, right? The less we think about it over the long term, what material we're using and everything else, the better that material is probably performing for us. So while these categories exist, these recommendations exist, my recommendation is seek a material that works well in your hands, that you're comfortable with the clinical performance with, and go with trusted manufacturers. Let's take a look at our dental landscape. Just a bit on longevity of materials. One of the things, and we take a look at a 2012 study here, one of the main reasons when we look at composites compared to amalgam-based dentistry is comparison of longevity rates. And we can have composite studies that show us very good longevity rates. especially when we look at the categories for why things fail based on fracture or caries. Predominantly caries, if it's secondary caries, which would be underneath a restoration, or caries, which is adjacent to a restorative surface. We know that the mechanisms for failure can be a little bit different than that, but by and large, they're not material type fractures, which people had some reservations about earlier on. But physical properties for these materials are certainly at a stage now where if we're appropriately placing them, we isolate the field correctly, really we should have good longevity to these. An interesting thing, if you take a look at another study, a comparative study taking a look at longevity of restorations and what are the biggest factors influencing how long a composite is left in the mouth. And one of the biggest influencing factors is whether or not you stay with the same dentist. We all remember from school being taught things that if something looks suspicious and you didn't place it there, you should take it out. And certainly when we are looking at our own work, we're more inclined to give it another 6 months or wait for the patient to become a little bit symptomatic. But in reality, us as the clinician is probably the biggest determining factor in deciding on the longevity of a restoration. And if you look at the last bullet points, when we talk about replacement of materials, if a material was replaced or if a restoration was replaced within 5 to 7 years after placement, the most logical reason or the most categorized reason for replacement was caries. And if the restoration made it 10 plus years, mostly the failures at that point are fracture-related failures, which can start to speak to the material itself. But the bulk of these failures are caries-related, which, as you know, may be operator error, not only from how we treat the materials, and that would really surface in adjacent to the restorative surface caries, as opposed to secondary decay, which might be left underneath or left within the confines of the prep, which would be more operator error. We saw a shift in dentistry where in the early 2000s, about 10 years ago, we really had high focus and demand on aesthetic dentistry. This led to us, from a clinical standpoint, having and adopting layers of trending and very complex anterior composite systems. We really needed direct options for patients that sought aesthetic improvements, but maybe didn't have the finances for indirect treatments like veneers or crown and bridge work. So we saw really composite manufacturers coming up with very complex systems. Really what we've seen over the last 5 years is an increased focus on business productivity. I assume you would all agree that based on the economy in the country and things that have happened, as clinicians, we're really focused on simplification of procedures, simplification of techniques, which allow us to get through our procedures more efficiently and more effectively, certainly without compromising the care that we're delivering to our patients. The way manufacturers have accomplished this is really seeking or developing materials that allow for bulk fill placement, so increments of considerably larger than 2 millimeters. We have a product we'll discuss which has a 4 millimeter indication. Several other manufacturers have 5 and or 6 millimeter indications. And I do have some reservations about curing above 4 millimeters based on ability for light to penetrate and the beam profiles of your lights, but those would really be part of much more expanded programs. We also seek materials for things that we can see, which is a fast polish, stain resistance. So some materials, while they have chemical structures that allow for them to have excellent physical properties, actually are subject to staining and to losing polish or losing luster over time, both of which to us as clinicians are visible signs, not only to our examinations, but to the patient's eyes as well. So things that were factored in on. The most common procedure we perform in the office today is posterior amalgam replacement. When you factor in the longevity of restorations and how frequently we're placing these restorations, within the next 5 to 10 years, the most common procedure we'll perform in the office will be replacement of posterior composites. So that brings, again, this simplification of techniques, desire for us to bulk fill, needing materials that adapt well to the cavity preparation, all becoming more and more of paramount importance as we go. Direct composites themselves, we all know this, are very aesthetically pleasing. The wear resistance and contact creation and things that had been criticisms in the past really have been overcome by material science. We really want to focus in on conservative preparations and then really applying our armamentarium of materials from our isolation system to our composite system to our adhesive system correctly so that we can maximize the benefits of these products along the way. So let's take a look at a spot of interproximal decay. You guys can see the incipient lesion on the distal of this premolar. Current day or modern day preparation for me really is not more than creating a slot box. We really obviously want to make sure that we're removing or excavating all appropriate decay. And other than that, we really don't need to focus in on extension for prevention concepts. There is no better restorative material than the natural two structure itself. So I try at any cost to preserve as much natural two structure as possible. So extension for prevention concepts, again, which had been created for material limitations, for delivery limitations, really have less functional place in today's operative dentistry world. So our clinical slop preparations here, you can see several examples of those. And what you see highlighted in the bottom right-hand photograph, the two arrows pointing really at the exposed margin or the exposed enamel available at the margin. And that really brings up one of the first critical things that we'll talk about, and that's adhering correctly to substrate. So if we have enamel available and we're doing an adhesive-based procedure, we really want to look at whether it's appropriate or how appropriate it is to etch those areas, and at the same time not give up some of the benefits of what we've had in products that are designed to reduce sensitivity and really make the patient experience that much better. Here's a picture of quadrant-based dentistry using a retaining system, which is a sectional retaining system that we'll talk about in a bit more. This was an early Paladin system, and we have since had an upgrade of this. But I use this slide because it shows that while we believe we're making progress, there is always room to improve on what we're working on. So a couple of the things that we had seen in these systems are the inability of these materials to really adapt very properly or very correctly to the tooth anatomy. So here you have non-flexible rings, which are trying to make contact with convex surfaces, which really just leaves single point of contact between the retaining ring and the natural tooth. And for those of us that have used early generations of sectional matrix systems, we know one of the things that can happen is the ring can be very unstable. And I'll address how our new Paladin Plus system really addresses that and creates superior isolation to anything we've seen in the past. You have to recognize that composites kind of fail in a different way than amalgams fail. We often see cuspal fractures, tooth fractures, and things like that happening with amalgam-based failures. But the reality is in adhesive-based failures, we have a number of very sensitive steps and very challenging application techniques for the clinician. And these failures can lead, these techniques rather, can lead to failures in other modes. Here you can see an example of a restoration that has poor marginal adaptation on both the mesial and distal proximal boxes. We could have matrix bands that are kinking or bending on their way into placement so that we don't have good adaptation of the band to the tooth structure. We can have, in general, wooden wedging and things that are creating false anatomic contour. So you can see on the right side of that, you have almost a concave surface next to a convex surface on the mesial of that molar. And certainly all of these can impact very significantly the longevity of our restorations. So we're really going to, again, hone in now on our class 2 solution. And what we're really focusing in on is trying to tie products together to give the dentist a solution to a clinical problem, not just expecting that we will adopt products because of differences in physical properties or delivery systems, but really, again, trying to package products that were designed together to make us more efficient and more profitable in the office. So we'll go through our Class 2 solution. Class 2s here, and as clinicians, we can look at restorations that are less than 3 years old, and there's certainly a lot of things that could contribute to this type of success. When we look at the marginal discoloration, the shadowing underneath those, that can lead to, from our standpoint as clinicians, both diagnostic questions as well as functional questions regarding longevity of this, if the patient is comfortable and things like that. So these are clinical challenges for us. And as we know, this challenge list can be very long. We have isolation issues. We have the issue of abrading adjacent natural teeth while we prepare. How easily we're able to get the band in place, again, without bending or kinking the bands. How well we can seal not only the gingival margins, but the line angles of our proximal boxes so that we can reduce the amount of flash and excess composite we have on tooth structure. Looking at our adhesive step towards creating a good and functional and intact hybrid layer, towards proper light curing and achieving an ideal contact with the application of a matrix system. But as you would agree, as clinicians, there is so much that goes into a successful restoration that we have quite a number of challenges to overcome. The number one, and place we'll start, is abrading the natural tooth during preparation. So when we take a look at it, iatrogenic tooth damage can be one of the things that kind of perpetuates problems for our patients. So here you have a look at a wedge guard, a Paladin Plus wedge guard in place. You can see very nicely on the right-hand side of that screen, and all the burr marks as we've prepared that DO restoration on that premolar. Well, functioning against a porcelain crown, you can imagine if all those burr marks that are on that wedge guard were now on that porcelain surface, potentially we could have an area for the patient where it's difficult to floss, where they may fray floss as they're using it. And over time, we know what patients do. They assume the path of least resistance. They start not flossing in that area. Before long, we have a single site periodontal defect and a problematic area on our hands. If we ever need to replace that class 2, we know we've made our life more challenging. If that tissue is chronically inflamed and difficult to work in, we may prepare that tooth for a replacement restoration and not be able to effectively isolate in that area. So something as simple as not abrading the adjacent tooth during preparation can have a significant impact on our restoration. Here's a good look at those Paladin Plus wedge guards. We'll talk a bit more about the wedges, but really an excellent design here, allowing the anatomy of the flexible wedge really to stabilize that wedge guard, and again, the positioning of that wedge guard against the adjacent interproximal surfaces to allow us to work not only with more confidence and speed, but obviously with a better predictive outcome for the patient, in that we have a very low probability of iatrogenic damage to the adjacent teeth. Here's a picture of that wedge guard in a clinical situation. As you can see, slid in between the teeth as we begin preparation, and as you can see in the lower right-hand portion of the screen, still in place at the completion of that DO preparation. One of the things I'd like just for a second to talk about is fluorescing properties of a composite. Here you can see several different composite samples, and as we just talked about tooth preparation and some of the factors and trends in dentistry, I also identified that one of the things that is happening quite frequently is that we're replacing posterior composites. Well, one of the challenges associated with that is correctly identifying what's natural tooth structure and what's actually composite material. So we can use fluorescence to our advantage. Several schools are actually utilizing blacklight flashlights. University of Buffalo is one, but teaching their students that upon initial preparation or upon completing the initial preparation, we then shine an alternate light source onto the tooth structure and identify for ourselves any residual composite. So as clinical educators, I just wanted to bring that point up to you guys. I recognize that this may not be a product specific to our portfolio, but certainly as a concept and as a theory can help us as clinicians deliver even better dentistry. But back to our matrix systems. When we look at matrix systems, we have really two choices. One are Tafelmeyer or circumferential bands, right? Something that wraps entirely around the tooth. And then our sectional matrix systems like our Paladin Plus system. Really, that Tafelmeyer can often fail to restore proximal anatomy correctly. We can often see, because we've been using wooden wedges, kind of triangular shaped interproximal areas as opposed to well contoured or well rounded interproximal areas. You see that triangular shape pointed out by the red arrow on the top portion of the screen, and the more well-rounded or naturally contoured anatomical area created by the sectional matrix on the lower part of the screen, designated by the green arrow. As we know, improper contour can lead to food traps, can be causes of potential failures and fractures of materials, as we can see here in the area. Um, and here we have a triangular shaped area. This leaves very little room or support for this composite, and this is one of the areas that is most prone or subject to fracture over the durability or lifespan of that restoration. I'm sure our sales group can provide you guys with some really nice literature. Here's just a layout of all the individual Paladin Plus pieces and all the individual components, from both the wedges and the wedge guard to the pin tweezer, which doubles as a ball burnisher, and I'll show us a slide on that in a moment, to both the narrow and standard rings, which really speak to the versatility of the system to be able to handle basically any challenge or any application into the mouth. Our matrix bands, and we actually have an upgrade days away to a coated band or a slick surface band to prevent composite and adhesive from sticking to that band during application, and as well as our forceps at the bottom. So we want to look at providing tangible solutions, again, looking at how functionally we can apply the materials easily and more correctly into the tooth, and how that will lead to better procedural efficiency along the way. Our Paladin rings, you may notice by the design of these, really at the base of the rings, we have the most curvature. This is the area that is, the rings are designed most to make contact with the tooth. That makes these rings exceptionally stable, even when we're missing a cusp, and I'll show you a slide on that in a moment. Another design feature you see is kind of this V-shaped indent here. This serves almost as a blinking light type of target for us when we're placing the wedge intraorally. We really just want to aim the point of that wedge in between these V-shaped notches, and the wedges will really work right through the interproximal area and the matrix ring. So again, a system that's very well designed from wedge to ring to matrices, really to work together efficiently. When you look at our sectional matrix system against some of the competitive products, here you see on the left-hand side an earlier version of a Triodent ring, our current Paladin ring, and the current Garrison rings. As you can see, just from a clinical application standpoint, these rings are smaller, they're narrower, and it makes them in application more versatile. The Garrison rings can be troublesome, especially for me. I was a very vocal Garrison user several years ago, and since then have kind of changed the products and my sequence of use. These rings tend to be very difficult to place in mandibular second molar areas due to external oblique ridges, and in the maxillary molar areas because patients are often opening very wide and making their tissue and musculature very taut, and they would have a tendency, due to the oval shape of these rings, circular shape of these rings rather, to dislodge these rings or create some instability or movement among those rings. So I would tell you quite honestly, I believe that the Paladin Plus system, both by design and by functionality, has superior clinical advantage to anything that's on the market. When we look at these wedges, again, these wedges will come in multiple sizes. You can see the indents anatomically, which should line up around interproximal areas right here. You can also appreciate the hollowed out area and the V-shaped kind of target that we were mimicking before in the ring. These wedges are also designed to stack because they're hollow, and we're encouraged to wedge both from the buccal and lingual because these wedges will kind of hollow fit inside one another, and I'll show you slides depicting that in just a second or two. Here we see some of the matrix bands in place. These matrix bands have rolled marginal ridges. These marginal ridges are designed to line up with the adjacent interproximal anatomy. These little grip tabs, which assist us in delivering the matrix into the mouth, are then intended to be folded over the adjacent natural tooth. That again acts as a barrier from getting composite or anything else on that tooth, and also gives us a real nice target from an anatomical standpoint for how high we should build our marginal ridge, which again would then impact how much occlusal adjusting, how much finishing and polishing we needed to do. So some of the subtle benefits, right, from rolled ridges to protective mechanisms within the design of these products are really, again, put in place to make us more efficient as clinicians. Here's an example again of that wedge guard in place. You can see from this film to this film some of the damage here. And these are also designed so that we can use these pin tweezers, remove this wedge, just kind of back the wedge out without completely removing the wedge, and then we can slide the matrix ring, the matrix band rather, into place without completely disengaging the wedge. That's something, if you're running through the technique part of that, if you have those trial kits in front of you, or if you're gaining some assistance by whoever else may be around when you're evaluating these, recognize that this is designed from the wedge guard to be able to retrieve this guard, back the wedge out just a little, and then put the sectional matrix in without having to change the wedges. As a clinical tip, one of the things about using a wedge guard is we're putting that in pre-operatively, right? It's the teeth are often already in contact with one another, so it isn't always easy to slide that wedge guard in place. One clinical tip is I use the ring to my advantage. I anesthetize the patient, and then as the patient is getting numb, I'll place that ring on the tooth we're working on. That has a couple of advantages. One, it will give me a good view of how the ring is going to contact the teeth. I'll get an immediate sense of how stable that ring will be in place. And second to that, the ring isn't smart enough to know whether or not we've prepped the tooth. It knows it's designed to create space. So we leave that ring in place for a minute or two. What will result is you'll see an open interproximal space here. You then can remove the ring, slide the wedge guard in, and begin preparation on the tooth. So just a little clinical tip for how to facilitate separation of the teeth and gain placement of the wedge guard prior to preparing the tooth. I hope that tip will help. Those palette and pin tweezers here are designed, again, not only to deliver that matrix in the mouth, but these rounded ends here are made to act as ball burnishers, so we don't have to instrument switch to get that accomplished. Here you can see, even with a stable, the rings are stable, even with a missing cusp. So you can recognize, I hope, that both by the design of this, the convexity of this surface, right, you can really see intimate contact on 1, 2, 3, 4 points against the tooth. Much like a table, this design becomes very stable. We spoke earlier about design of sectional matrix systems, and I mentioned that one of the problems is getting the ring to be stable because the ring is designed as a straight point and the tooth surface itself is very convex. So again, just proof that the ring system itself is going to give us good clinical advantage. Then we use that ball burnisher once we're in place. Here you could see that grip tab would then be folded over this adjacent natural tooth. We would have this rolled marginal ridge and the grip tab, again, as targets for building up the restoration as we go. Here are examples of those anatomic and flexible wedges. Obviously, we're going to work from smaller down to bigger, or if you're working up, from bigger first down to smaller, so that we can create naturally this somewhat triangular shape, right, as we're moving up interproximally in the tooth. So good for periodontal applications, for extreme cases, again, due to this V-shaped design. These rings are also well designed to be easily stacked and really facilitate us in quadrant-based dentistry. Here you can see just an MOD application, one matrix ring placed on the distal, one on the mesial. We could also use this in an application where we place a Tafelmeyer band around the tooth and then use rings, and I'll show you a photograph of that in just a second. The stability with missing cusps, again, comes from the fact that the retention tips are so low down on that ring that it makes it very, very stable as you work. A competitive advantage over that Garrison system, here you can see there's these non-mobile tines in the middle of this, in this flexible area. So what happens is we can actually create an anatomic deficiency right here. Here's the Paladin ring overlaid over that Garrison restoration. And you can really see how this non-flexible piece can create an area where we might later need to modify before letting the patient proceed. Here's an example of using a Tafelmeyer, so circumferential ring with a single circumferential band rather, with a single sectional matrix ring. Just some different designs and configurations. Here's that same configuration clinically. Again, recognize how wide this preparation is, yet we have 4 very stable points of contact for that matrix ring. Again, just another application. Here we can actually do MOD or restore 4 adjacent interproximal surfaces simultaneously. We can use a Tafelmayer around one tooth, a Tafelmayer band, a sectional matrix band here, a sectional matrix band here, and just 2 rings, and very confidently simultaneously restore 4 interproximal surfaces and generate very tight interproximal contact along the way. Again, a mechanism to get us very in tune with quadrant-based procedures in a very efficient and predictable manner. Let's talk a bit about adhesives. Adhesives are very significant in our clinical practice. We're using this in bonding all composite cavity classifications. Certainly when we're doing crown-based procedures, looking at resin-based cements, and as we talk about indirect applications for bonding in post and cores. We'll obviously be focusing on the direct bonding piece today, but the recognition is that adhesives are a material that we use virtually every hour in our practice. The marketplace itself is very split between self-etch and total etch products. Most dentists, in fact, 60% or more, report that they use 2 or more adhesive products. Clinicians do acknowledge that the preparation, the location, the substrate we're trying to bond to are all driving factors in what materials we use. And while clinicians tell us that they look at the substrate after they prep and then choose the adhesive product to apply there, I would argue that most of us are doing the opposite. We're picking a product and then applying that regardless of what the restoration or what the preparation looked like. I think as we move forward, though, we really do want flexibility and the ability to treat different teeth in different ways, even within the same quadrant, within the same hour that we're working. So the ability to elect how we use a product makes much more sense for me than just categorically seeking a material. We look at use of phosphoric acid, and certainly that can have some implications as to developing post-operative sensitivity. We want to make sure that we're using these materials correctly and appropriately. But as a general rule, if we have enamel available, we want to etch it. The most established and most durable bond that we know is a bond to etched enamel, so we want to capitalize that on whenever possible. We know our evolution of our dental adhesives. We've seen through the years many different adhesive systems come along the way. Most recently, we've seen the emergence of a universal dental adhesive category, and there were several products in that category, from our product to Scotch Bond Universal, a 3M product, Optibond, which is a Kerr product, and All Bond Universal, a Bisco product. All of these are really designed to allow the clinician to apply the material as they see fit based on the clinical circumstances, and I think that's what we really want. When you consider that the reasons for sensitivity, and again, this drives us, post-operative sensitivity is one of the driving forces in adhesive selection. We're impacted by how well we etch the dentin, the success of us drying or appropriately drying the dentin, how well we can evaporate solvents, how well we cover the tooth with the adhesive material, how well we can polymerize the material, and then certainly what composites we put on top of those adhesives. But really, the smear layer has been what dictates these different generations of adhesives and the chemistry along the way. We talk about moist or wet bonding, and one of the things that we referred back to in the past is enamel we always looked at really desiccating. I mean, we were proud to show our dental school instructors how frosty white our enamel was. The reality is this has a negative impact to the dentin, right? It's very difficult to dry enamel and not have negative impact on the dentin. So even enamel these days can be moist. We want to be able to work in a naturally hydrated field without pooled moisture. But based on recent chemistry, the materials, the primers themselves are all very hydrophilic, allowing us to take and carry resin even into areas that will have some moisture present. Evaporating the solvent, a very important part of what we do, often overlooked, but recognize that following the instructions, many manufacturers are advocating a 5-second airstream in order to evaporate the solvent. Recognizing it's particularly important to eliminate that solvent and leave ourselves with a very resin-rich hybrid layer. So we want to make sure we're really emphasizing the idea that 5 seconds means 5 seconds. It's also difficult not to contaminate a working field considering how close the air and water tip may be. Just one clinical tip I would suggest after using a water spray, don't directly go to air, but have your clinicians blowing a little air outside of the mouth to make sure that there's no moisture or contaminant still in the line. And then it's always a good idea never to directly blow air into the tooth, but I'll use indirect air application. I'll angle my mirror just above the occlusal surface and actually blow the air onto the mirror surface. That way I can see if there's any residual moisture on the surface of the mirror, and at the same time reduce the potential of putting a very heavy airstream into that and kind of blowing that adhesive right out of the preparation. So Prime and Bond Elect, we can use this material as a total etch product, as a self-etch product, and what I really believe is the most likely application is in selective etching, and that's really the idea that if we have enamel available, we want to etch it. When we look at clinical situations, it's difficult to say that we always want to apply a material in a self-etch or total etch mechanism because preparations vary so much. So we could have a very large cavernous class 1, which could be predominantly dentin, very little enamel available, in which case self-etching might be the best opportunity for us. But here you can see a completed class 1 entirely in enamel. This preparation, in order to be successful, must be total etched, right? We wouldn't do very well with self-etching here. Self-etchings generally don't do very well on uninstrumented enamel. That's due to their slightly higher pH. pH is in the 2.2 to 2.5 range. But in all fairness to application of those materials, this is an indication for a total etch application of those materials. Looking at etching themselves, this is how those steps would look. So total etch we're all familiar with, phosphoric acid both on the dentin and on the enamel. In self-etch, no use of the phosphoric acid, just of the adhesive-based material. Self-etching materials are often scrubbed into place. And then selective etching, so use of the phosphoric acid on enamel without incidental contact onto the dentin. In order to accomplish that, you really need an appropriately designed etchant gel. These gels vary. The gel on the left is our etchant gel. The gel on the right is one from another manufacturer. The realization is that if you're looking to place an etchant gel and have it stay on an area that you want, you really need that gel to be viscous. So you could assume if we were looking at these two applications and we wanted to apply it just to the enamel, it would be very difficult to have this material stay on enamel and not get onto the dentinal surface. So again, paying attention not only to the components, but to the instructions of utilizing the materials as well. There's a clinical photograph of that selective etching procedure. Again, here you can see that etchant traced along the peripheral border of that prep. And again, recognizing with a much thinner gel, this gel would have a high tendency to run into the prep and to have contact with the dentin. With this system, with Prime and Bond Elect, there is no worry if you do have contact with the dentin and are intending only to etch the enamel. As I've already mentioned, we could use this material as a total etch product solely or as a self-etch product, which means the product chemistry is very robust. It has a lot of forgiveness to it, so it's very easy to generate a good bond and still be within a safe zone of not having a high probability for post-op sensitivity. In fact, we're just completing 1-year clinical recalls at the University of Pennsylvania, but at baseline, so after material placement, of 150 restorations that we placed, 0 had post-operative sensitivity using this system. So a very nice clinical result for us as well. Application of phosphoric acid. When we look at it, we know that we want to etch enamel for longer than dentin. I would encourage you guys, as you have your clinicians apply the phosphoric acid gel. Most of us start at the base of the prep and fill the entire preparation up. It is impossible to etch dentin for less time than enamel if we start by placing the material on the dentin. We have to follow good technique, trace the enamel borders first with the etchant gel, then work our way into the prep and fill up the dentin. This is the only way we can assure that we're etching the enamel for longer than. Selective etching, again, I showed this photograph before. If we have enamel available, we want to make sure that we are going to go ahead and etch that. Here's another good clinical example of that. So here, one application with a reasonably wide prep easy to just trace the enamel and not have incidental contact on the dentin. However, in a much more confined or restricted preparation, it's virtually impossible to etch just the enamel without having some incidental contact on the dentin, which again, for a system like this, really speaks to the robustness of it. So for a very popular self-etch system like Clearfill SE Bond, their instructions read to avoid incidental contact of phosphoric acid gel on the dentin if you are choosing to selectively etch. Here, there's no problem with that. Again, you can use the material in a total etch mode, so it really gives the clinician the ability to apply the material as they see most fit. I show this slide only to tell us that this is based on self-etch chemistry, which means you do have to scrub this stuff in place. Remember, with total etch products, when we're replacing the actual adhesive, we usually just paint it on and allow it to sit before we air thin it. Here, we actually need to physically scrub that material in place before we air thin it. So just again, an acknowledgement of the directions for use and an encouragement to reinforce that with your clinicians as they work. Prime and Bond Elect also is noted for very low film thicknesses. This was something that our Prime and Bond line has been known for years. That can impact us specifically regarding visibility of the adhesive on a film. So for thick adhesive materials, and Clearfill SE Bond is again one of such materials, we can have these areas that look almost like radiolucencies, which as we know as clinicians mean there's either a void in the restoration or potentially secondary or recurrent decay. The reality is it may just be thick adhesive, but that opens us up for the opportunity of misdiagnosis, of poor communication between clinicians, especially in multiple practitioner offices. So something as benign as even film thickness can be very impactful to the longevity of the restoration. We have some really nice test data to show the consistent bond strengths you get with Prime and Bond Elect, whether you use it in total etch or self-etch modes, and whether you're attempting to bond to either enamel or to dentin. So the consistency of this product across substrate is excellent. We also went out of our way to test this with our base materials. So Surefill SDR Flow, which is a popular flowable bulk fill 4mm material, which acts as a base. I know we'll discuss that in just a second. And we've got really nice test numbers to show bond durability to that. Against competitive products, again, if you're looking at deciding between products, a significant advantage over the second most popular product in the universal category. To touch on light curing for a second, we know that proper light curing can have a lot of impact on the restoration longevity, and this is often something that we overlook. We have several educational programs which can really reinforce and emphasize something of a step which we view as to be as simple or insignificant as light curing, how that can impact the longevity of your restoration. One of the things to factor in most is how close we are to the light source. So quite often with things that are shallow and close to the surface, 10 seconds with 1,000 milliwatt or 1 watt light is no problem. What happens quite often is we're up to 8 to 10 millimeters away from our adhesive or our base material as we're beginning to cure. That's due to the fact that our proximal box anatomy is generally 6 to 8 millimeters deep, plus the cuspal inclines, right? So we can often have our light source at least 8 to 10 millimeters away from cervical margins. Transfer of energy can depend a lot based on the light design, so how well we're able to angle this against the restoration. We also know from studies that operators can vary quite a bit based on their technique and how focused they are when they're looking at these materials. And we have a significant upgrade to our light portfolio coming within the next couple months. Well, we've got the adhesion, we've got the isolation complete, we've got the adhesion complete. Let's talk about application of the composite material. And one thing we really need to discuss is not just volumetric shrinkage of a material, but what's more appropriate, and that's polymerization stress. So what stress is what happens to the material as we begin to photopolymerize it. And as a laundry list of things that can happen, they can impact marginal integrity, the adhesive interface, have post-operative sensitivity issues, and over the long run have micro leakage and secondary or recurrent decay form as a result. So as definition, shrinkage is the process of volumetric contraction upon curing, and stress is the force that shrinking composite exerts on the tooth. The way we look at volumetric shrinkage is that's measured when the composite is unrestrained. So what we do is take a volume of material, apply a light source to it. We take a volume of that material pre-light application and then post-light application. The difference between those two measurements is volumetric shrinkage. That's interesting, but in reality, we never apply composite into the tooth that way. Composite is always bonded to the tooth. So there's a much more relevant mechanism to look at, and that's stress. So in this system, we have a much more complicated measurement. There's machinery which has silanized glass slabs, which then have composite placed between them. The same idea, we're taking a pre-measured volume and applying a light source to it. As that light source is applied, the cured composite will begin to constrict. That will put some force on our tensometer, and what will happen is we'll get a resulting measurement of stress. This is a considerably more relevant number than volumetric shrinkage, and materials of equal volumetric shrinkage can impart significantly different stresses to the tooth. And that is an important thing we have to consider, especially when we look at unexplained postoperative sensitivity, where everything appeared to go well. We had isolation well, our field was clean, everything worked well, and we still have postoperative sensitivity. One likely explanation can be the stress that has been imparted in the tooth from the polymerization mechanism of that material. If the stresses are too high, it can impact the material in several ways. It can break or diminish the adhesive interface between the adhesive and the tooth. It can also have damage between the tooth and the adhesive interface and the composite. And if the composite is bound to the adhesive well enough, it can actually cause microfractures within the tooth structure itself, which can lead to things like cracked tooth syndromes. So again, stress is a very relevant and pertinent number. This has existed for a while in dental conversation. We've dealt with this through terminology called C factor, which is the number of bonded walls versus the number of unbound walls. So in any restoration, we could have 6 walls, 5 of which would be bound at any one time. The composite on top might be the unbound wall. So when we translate that, the way we've worked around that clinically is by placing increments of material. Well, the reality is we've connected the same number of surfaces in every horizontal increment that we place. We've seen techniques advocated of vertical layering. This is very difficult considering 1, application, and 2, how conservative preparations can tend to be. So stuff like this, while in theory is terrific, in practical reality can be very challenging or near impossible to do. Stresses vary based on what category of preparation we see. And the highest stresses are these ones that look the easiest, right? These are the number of bound walls is 5, unbound walls is 1. This, which looks like that little pothole class 1, remember we hit our easy button to start this program, looks like it could be the easiest of stuff that we work on, when in reality may be the most challenging. So SureFill SDR flow, a bulk fill resin material, 4 millimeter increments for placement. There's comparative shrinkage stress tables for you to look at with your groups to let you see that even though this material has been on the market for 3 years, no competitors have really come close to what our stress numbers are. You can see the shrinkage stress numbers here, but volumetric shrinkage numbers are all very similar. So again, stress is a very relevant and applicable statistic that we're looking at these days when evaluating materials. We also want the material to adapt very well to the tooth structure, so we want something that is self-leveling and truly flowable. Some materials tend to be stackable, flowable materials like you see here. We really want something that levels and seeks a good adaptation, and SureFill was designed to do that. This material also has very high radial opacity, which leads to us being able to visualize these materials very easily on a radiograph. So we can see very little transition between our natural, our base resin and our capping resin, but we can see excellent transition between our restorative material and our natural tooth. So I would encourage you to use materials with high radial opacities. As you can see, the radial opacity for natural enamel is 2.0. The scale for dentin is 1.0, so we would always want restorative materials with a radial opacity higher than 2.0. Radial opacity is important, as you can see, we just explained in the previous film, but when we have mismatched areas of opacity, it can look like this clinically, which makes us scratch our head and want to replace those restorations, even though it's possible that this is a completely functional and good restoration for the patient. Moving along, this is actually a film. I had the scientists create a material that had a radial opacity of under 1.0. Even though this restoration is completely filled, it looks as though there's no restorative material in that area. So that's just a visual to show you how impactful high radial opacity versus low radial opacity can be in a material. Here's a clinical case using SDR with our Paladin system, using this as both an endodontic sealer as an extension of the base to get good adaptation. Here you can see those Paladin rings and that tab, as we mentioned, folded over the adjacent natural tooth. And here you can see radiographically at the end the good visualization of that high radial opaque material on that X-ray. This also presents significant placement time advantage. When you look at incremental placement versus bulk fill placement, the conventional procedure, SureFill SDR flow, can reduce our placement time by about a minute. That's a significant amount of time when we consider that's the window that our restoration is most vulnerable. 4 millimeters of placement is an indication, not a rule. Sometimes if I have very deep, dark stained tooth structure, I'll use a much smaller increment of SDR so that I could build up the opacity with my hybrid composite that much more and deliver a more aesthetic and good restoration for the patient. We can use this delivery system to our advantage. There are actually markers. This SDR compule, this cannula is 6 millimeters long. We can use this as a guide. So basically 4 millimeters up the cannula tip. We can tell our clinicians if you're almost at the top of that metal cannula, you've probably placed 4 millimeters and that's enough. So again, just using the instrumentation to the best of our advantage to provide good visuals. Just a minute on that capping composite, TPH Spectra, and we'll be all set with our program. We know that in real estate, it's all about location. Well, in dentistry, it's all about handling. We want to seek composite materials that will not stick while we're trying to instrument them to a cavity floor, such as this in an occlusal application. It's very difficult for us when we're pressing down on composites and having them fight back with our instruments. Also, because we're often freehand building anterior teeth, right? Free-handed in space, we need materials that are non-sticking and non-slumping once they're in place, so that again we can maintain the anatomy we're working so hard to develop along the way. TPH Spectra has a very unique approach. We designed that to be a dual viscosity material, so there's both an LV and an HV version of that. We've incorporated a simplified shading system with which just of 7 shades we can cover the entire Vetus shade guide. This is due to the chameleon effect of that material and its ability to blend and shade match. This also demonstrates an excellent stain resistance and a very high polish or initial luster. Depending on technique, this would be an application of an LV material, a low viscosity material, and kind of a buttering technique where we're spreading that material along. That will just be individual clinician preference. My preference is for a packable feel. I like very stiff material when I'm packing in the posterior. So for me, I would be using HV materials in there, but not for physical property preference, just for handling preference. So here the physical properties between the HV and the LV are very similar. The real difference is in handling, and that's designed in there to appeal to clinician preference based on where they're placing the material. Continuing on to develop good anatomy and good contour in that, use the existing instrumentation, right? Find the grooves within the tooth and spend time pre-cure of that material to develop the anatomy. It's better to do that now than with a burr later. The burr is going to make the surface of that very rough, difficult to finish and polish, and it actually saves us time spending more time instrumenting the material than it will during finishing and polishing. And here the completed restoration. There's a summary of TPH Spectra's physical properties, all very competitive. Again, not necessarily a market leader in any one single category, but when we look at this TPH line of composites and the tens of millions of applications we've had with this material. We know these physical properties to be those that will be very successful clinically, and have a lot of confidence in this material that, based on the fact that we're providing clinician with preference in handling, that we'll have a very popular material on our hands. The simplified shading system, as I mentioned, 7 shades will cover the entire Vita shade guide. We have a conversion chart. I'm sure that's in all of your sampling kits and would be provided to you by the sales groups. The LV and the HV both have these 7 base shades. We do have a complete line of complementary shades only available in an LV viscosity, not both viscosities. But if there are some odd shades and odd teeth in your practice, you basically would be able to find all these multiple shades. But we're very confident that with only 7 shades, you can adequately treat almost any tooth in your office. Here's another conversion chart for that. The way this would be read is a B1 Spectra shade would be able to fill a B1, A1, or B2 natural tooth. Here an A3 Spectra shade would be comfortable within the match of almost all of these natural tooth shades. This is based on science of a color change mechanism called delta E. We're not the only manufacturer who's pushing this type of shading system now. Curare is another manufacturer, and Tokiyama are both manufacturers that are pushing similar stories. So there's relevance to that because of how quickly our eye can pick up changes in color, and there's quite a bit of science behind this. We looked at this by placing these materials within the centers of shade guides. We then did both internal and external evaluations to make sure that our visuals matched with the science. And again, these are exercises that your clinicians could always do to show themselves and build confidence themselves that they'll get good shade matching across a variety of shades. Keeping the tooth hydrated is an enormously important part of what we do. A tooth can change shades up to 6 shades in an hour just under rubber dam isolation, so just from a dehydration effect. So it's important to select a shade at the beginning of the procedure, not after the tooth has been dehydrated for 45 to 60 minutes. So again, just another clinical tip there. Even though I've been talking for a while and I may have you seeing stars, if you're looking at this screen right now, there are no moving components to this. What the purpose of this slide is to show you that during shade selection, we actually have some limitations of our brain and our eyes that are working against us. So here, even though you may see black dots appearing all across the screen, there really are no black dots there. They're just white dots in the center of those black and gray lines. And this is just showing us that our eye is seeking complement to what it already knows. Another example of that, if I could ask you guys to concentrate on this X in the center of this tooth as I talk for the next couple of seconds. What will happen is your eye will begin to seek complementary colors for the red and the blue. So again, I ask you guys are focusing on that X. Over the course of the next couple of seconds, I will switch that slide, and what you will see is your eye seeking a complement to both the red and blue. So I hope that worked well in a webinar format. You should have seen most of the central portion of this incisor as blue and the peripheral border showing up as tan. Again, that's not eye trickery on my part. That's your brain working against you. So what we want to do is advise you to take shades in short increments. These are 2, 3, 4 second looks. We shouldn't be staring at a shade and taking a shade for 30 seconds. Shade can also be impacted by various light sources. Here are the same 3 shade tabs under fluorescent, sun, and incandescent light, and you can see how different those look. That is from a concept called metamerism. Again, all reasons why we can cover multiple shades with only 7 different composite syringes. Here again, the physical composites on those, looking at under incandescent, fluorescent, and natural sunlight, you can see how different those shades appear just based on the light source. Wrapping it up, background can have impact as well. So looking again at both the vibrance and vitality of all of these different shades against their background, it's important to recognize from the color of the bibs that you use to the color of your operatories, but everything can impact how successfully your clinicians are taking shades. I would encourage you guys as groups not to arrange your shade guide the way we've been taught in school, and that's by color, right? So A, B, C, and D ranges. In practicality, we should be arranging our shade guide by increasing order of value. This information can be found on the back of your shade guide. but the appropriate order would be to arrange from B1, A1, B2, all the way through, reading left to right here. This gives us the best opportunity to miss the shade, but still have an acceptable match. If we're deciding between an A2 and an A3, because we're in an A family, we can see that between an A2 and an A3, there are actually several more appropriate shades to choose from. This may take some additional explanation, but again, this is based on science, not on us or any manufacturer trying to mislead you with the number of shades that they're selling. Remember, we can get the shape of the tooth right and still miss the shade. Another factor that goes into us wanting to arrange our shade guide like that. So here, even though we've improved significantly on the shade of the tooth, the shape is mimicked well, but the size is off. This will still make our eye go towards this area, even though we've matched the shade quite appropriately here. But shape is paramount over shade selection. One last clinical case. Here's clinical decision making. If we had just made the decision based on what we were talking about, deciding between an A2 and an A3, so a wide variation for error, just to show you some of the flexibility of this system. Here's that class 3, which turns out to be a through and through class 3. Here you can see the demineralization here, both from the lingual and buccal surfaces. After completion of the prep, right, we can really appreciate the irregular enamel border here, how we need to have good enamel availability towards the incisal edge aspect there. So what we'll do is apply our selective etching technique, etching all the unground enamel on both facial and lingual surfaces, applying enamel to the available enamel along this marginal ridge. Here you can see evidence of that etched enamel, right, that frosty appearance. We're going to apply an LV, which is a creamy material, into this class 3. We'll then bend this mylar strip against that tooth anatomy to recreate that shape. If I was using a thicker or HV composite, I probably wouldn't have as much success just kind of bending or wrapping this mylar strip around the tooth. There's the completed restoration, so excellent form, and again, good light transmission, and a very good aesthetic result for the patient. In a class 4 application, here my preference replacing this white spot lesion and this little enamel defect would be to use an HV material, a more packable or stiff material. Again, could be accomplished with either, just my clinical preference. Here, because we're on enamel, we're total etching that enamel, right, both on the facial where we're replacing this white spot and on this incisal edge defect. And again, you can see excellent chameleon effect. Even in a multiple shaded tooth, we have that composite resurfaced in there and giving us a very nice high-end aesthetic appeal. Looking at that solution together, so here we've got a posterior application, a class 2, using selective etching technique, Palinate Plus as the matrix system. Again, here's our sectional matrix ring, good adaptation, good contact of the matrix ring against the adjacent tooth, and a high probability of success for this restoration. Working our way through that, here you can see those etched enamel margins. Applying here, Surefill SDR flow into the preparation. Good visual access because of this cannula tip. Again, looking at this sectional matrix bent over the adjacent marginal ridge to help us approximate ridge height and how much we'll be building that tooth up into occlusion. And as we proceed through these, the completed restoration on the right-hand side. So the dentist is really afforded the opportunity to get the best of what we want, both from an etching standpoint, from an application of material, whether it's a creamy consistency or a firm consistency that we like. And then the final step is finishing and polishing with our enhance and pogo pieces. I advise that cups are most appropriate for class 2s. This gives us an excellent opportunity to get this cup, open end of the cup, over a cusp in a class 2 and really work that through. The enhance are our brown mandrels. These are finishing. This will reduce the volume of composite. The pogo is really just to impart luster on that natural tooth, so finishing first and then polishing, again designated by brown and gray mandrels. The conclusion here, really looking at our program start to finish, is despite the frequency of composite placement, successful completion of a resin restoration is tedious and very technique sensitive. The longevity of these restorations can be related to us completing each of those steps successfully. Again, those steps being everything from preparation to isolation, our adhesive step, the composite placement step, and finishing and polishing. And that really what we hope we've provided as a group, as the CALK group from Dentsply, is a complete solution to your class 2 problems. So looking at utilizing our spectrum of solutions from start to finish, if we understand the clinical design and the potential benefits for these materials, we certainly believe that we can elevate the quality of care that we're providing to patients and not cause us efficiency, but actually make us more productive because we're working faster and with more confidence throughout those procedures. So for me, that's the end of my slides. I guess I'll ask if we could open it up now, Noah, to some questions, if there are any, and if there's any other information I can get you guys. No questions? Well, if I don't have any questions, I guess I'll hang on for just a minute or so in case anything else comes up. I'm sure you, as the group is aware, have excellent communication both with your account and local sales reps. So I would encourage you, if there are any things that come up between now and the next times we may speak as a training group, please address that to any of the sales representatives. And I can always be contacted directly. My email address is just my name, which is nick.conte, nick.conte at dentsply.com. I'm more than happy to address any questions you may have outside the framework of this program.